All right. Okay. And just do the share screen here. Is that what we're doing?
Yep.
All right. Okay. Can you all see that?
Yes, we can.
All right, good deal. Well, hi there. So my name is Megan Garza, and I am on the National Partnership for Ending Interpersonal Violence Action Team, along with Karen Rich, Susan Emilian, and Diana Barnes-Fox. And we're here, we're going to talk to you today about bringing trauma-informed care into your community, your practice, and your life. So the National Partnership for Ending Interpersonal Violence, for ending interpersonal violence across the lifespan, Global Partners for Peace. It's a great little collective of people that we bring together from all different disciplines, and we all work together we've created a national plan to end interpersonal violence in 25 years. And so this part about talking to communities about trauma-informed care and establishing principles for trauma-informed care and helping agencies and individuals be able to use trauma-informed principles are part of what this work looks like for us. So I'm not sure how much experience other people have had with trauma-informed care before, but you know, normally when we talk about trauma, you know, one of the most basic facets of trauma-informed care is understanding what trauma is. So, you know, I'm just going to say just very briefly, you know, trauma is, you know, really when something really bad or scary happens to someone. So when someone has experienced a natural disaster, when they've been through like a hurricane or tornado, or maybe they've experienced military trauma, community violence, perhaps it's emotional abuse, physical abuse, or very often sexual abuse. Those are just a few examples of some common traumas. You might see very common signs that come up for traumatized individuals. So as a result of trauma, there are very often short and long-term reactions to those traumas, things that could be things like irritability and sleep problems. Now, just to give you context, both Karen and I both work in the area of sexual trauma a lot, so we're going to kind of focus a lot of our presentation on examples around reactions to sexual trauma. So when we talk about signs of trauma, it could be irritability, sleep problems, seating near exits, avoidance of trauma-related topics, so just not wanting to think, feel, talk about anything related to trauma. We notice a lot of anxiety. A lot of people that we work with have a lot of difficulty with anxiety. They might have problems leaving the house, just making phone calls, making decisions, kind of like the world gets smaller and smaller and smaller. In general, there's just a lot of fearfulness. You might notice more tearfulness, sudden changes in performance. You know, an A student suddenly becomes a C or a D student. Someone who was a really, you know, top-notch worker at work suddenly isn't working so well anymore. And that might not just happen just when the trauma occurs, but when the memories of the trauma really resurge and they start to really experience those things that happened that they had suppressed from an earlier point in time. We might notice sudden changes in mood. Person may be more withdrawn. They might have a lot of mistrust, difficulty with recall. A lot of individuals, you know, might, you know, they might have compartmentalized aspects of the abuse and kind of tucked it away for a while. And then a lot of people will say, you know, like, I knew it happened, but I didn't really know. And then something happened and then poof, like it all just like came flooding back to me. We also see things like poor boundaries. So physical or emotional boundaries might not be as strong as they would like them to be. Some people describe spacing out frequently. And it can look different. Trauma reactions can look differently in children versus teens. So acting out the assault or just acting out in general, really. You might notice more isolation and tearfulness, a lot of suicidal threats or suicidal attempts, impulsive acting out behaviors like getting into fights or maybe destroying objects, reckless behavior, sometimes risky sexual behavior. Very often, if you see, when I do crisis outreaches, when I see someone who started abusing substances at a very young age, a lot of times the onset of their substance use and abuse correlates with the onset of their trauma. It's like right subsequent to that. Self-injury, cutting, scratching, burning, head banging, or hitting oneself. Um, and very often this is a form of anesthetization. It's sort of a numbing, focusing on the physical as opposed to the emotional pain. Eating disorder behaviors, excessive bathing or showering, and regressive type behaviors. And then changes in work performance. When we talk about what trauma-informed care is, so trauma-informed care is this principle that we're kind of reimagining trauma and how we respond to people. So instead of asking what's wrong with you, we ask what happened to you. It's our universal precautions approach to addressing people, to addressing behaviors and concerning behaviors. So when someone's in the medical setting, we've gotten really good to using, universal precautions. So if there's blood spilt, if there's a problem, if there's been an accident, we put on our gloves and, masks. Well, and so this universal precautions approach is the emotional way of doing it, which is instead of just assuming the worst, but like wondering, so like, what is going on? It's not that this has been a bad person or they've done something bad. It's what has happened? What is the context for this? And the key principles that we're looking at is safety. So we want to create areas that promote a sense of safety for the individual. We want to rely on trust. So you want to provide clear and consistent information. You want to give choice, provide options for treatment and care. It also uses collaboration. So maximizing collaboration between healthcare, staff, patients, and family, and empowerment. So building on a patient's strengths and experiences. So trauma-informed care really is a very strengths-based perspective. And when we use trauma-informed care, there are these 4 R's of trauma-informed care that we talk about. So realize that at all levels, people have a basic realization about trauma and how it can affect individuals, families, and communities. So just kind of like what I just did in that last slide, talking about kind of some basics about what trauma is. Resist re-traumatization. So organizational practices may compound trauma. Unintentionally, trauma-informed organizations really work to try to avoid this. So whether we're talking about schools, jails, hospitals, whether we're talking about a substance abuse treatment center or a mental health facility, you really want to work to avoid causing further injury. You also want to recognize that people within organizations are able to recognize the signs and symptoms of trauma. So if you help people recognize what they are, they're much more able to respond in effective ways. And respond. So programs, organizations, and communities respond by practicing a trauma-informed approach. So in this trauma-informed approach involves these 5 key principles. So when we look at this, when we look at examples of what this might look like. So if we think about non-trauma informed agencies, what you might see are perspectives where client behavior is seen as intentionally provocative, like they did that on purpose. That was intentional. They were just trying to get attention. They're just trying to get attention. That's all that was. That's what that suicide attempt was. It's all that they're just trying to get a rise out of us. Labeling language, so calling the client or the person manipulative, needy, attention seeking. They tend to be very closed systems, so they don't tend to like having advocates involved. They like to just utilize who's within there, and they don't like to communicate outside of their system. And it tends to be a very policy driven, about a one size fits all approach. So this is our policy, and they strictly adhere to this policy because this is what we established as what needs to be done so that it's fair for everybody. But like you might hear that word equity, that used a lot now. Equity, what's fair for one person is not necessarily fair for others. Some people have different starting blocks. um, eh, we want to enforce mechanism, or we don't want to enforce mechanisms of strict control or power over others, but that is what non-trauma informed agencies do. Um, they often enforce severe consequences for non-compliant without input from the client. They tend to be pretty inflexible. They favor procedures, policies, rules over the benefit and comfort of the client and staff, organization, and the system. They may use restraints, and very often it's a very much top-down approaches. So this is the rules that come on high. So you might recognize that there are certain agencies that, like this, educational institutions, correctional facilities, those tend to, and even in, those tend to be systems that very often, these policies can be pretty fixed and difficult to change. Um, Whereas trauma-informed agencies have staff that understand the function of behavior, aggression, self-injury, etc. Like, what's the real reason why they're doing this? What's going on for them? Are they cutting because they're trying to get attention, or are they trying to numb the pain? Um, they tend to use objective, neutral language. They have, and by that, so instead of that, it's manipulative. Like this person is really struggling, and they need some help right now. They have transparent systems. They're open to outside views, outside people coming in collaboration. They tend to make an effort to understand the unique culture of those they're working with and taking an empathic approach. So it's really a lot of perspective taking. They actively seek feedback from clients and staff about ways that they can improve. So, you probably see a lot of surveys from these kinds of programs. And you consider the client's comfort. You might ask permission for consent, confidentiality, and boundaries. You might make those really a big priority. And considering the impact of triggering behaviors like environmental cues, touch, body language, presence of weapons. Like, trauma-informed agencies really consider the culture and everything about, like, what is around, like what does that room look like? What's the positioning of the things? What's there? Who is there? How are they standing? How are they sitting? All those things, the lighting, how might those things impact the people that we are working with? Or the other people just in our community. You make self-care a priority for both clients and staff. So, like, you're really looking out for the benefit of everybody. And you ensure that the population has representation on the board or in decisions. So it's not just purely represented by people who don't have a vested interest or a knowledge of the experience itself. So I'm kind of starting you out with, I'm giving you like a really, really brief synopsis of what trauma-informed care is. And I'm gonna pass it over to Karen Rich, Dr. Karen Rich. She's gonna talk with you a little bit more about this topic.
Hello. Hi, this is Karen Rich. So I am going to discuss a little bit more about trauma-informed care, but let me just share my screen. I can only share it after this screen isn't being shared anymore. But
Okay,
I'll start without this.
There we go.
I just want to talk about some of the obstacles to help seeking for people who have a trauma history. One is that there's a lot of social myths about different traumatized populations, such as rape survivors, obviously, veterans, battered people. They face a lot of social judgment based on the populations they come from, because we are a victim blaming society. And so when you go into an organization for help, often you can encounter personnel who also have those values. The other thing is some cultural prohibitions about seeming weak or defenseless, especially male survivors. It's not consistent with the male gender role to actually need help. Intense shame, a lot of the victimization causes people to feel ashamed, and there's also a fear of confidentiality violations. If you say something about something you've experienced that's intensely shameful, how do you really know that that's not going to find its way into the hands of authorities or people who could misuse the information? And even translators can hail from the population, the indigenous population, and can be associated with the community, the subculture, where you don't want that information to be shared. And last is re-victimization fears. It's unfortunately very true that people who have a victimization history are often predated upon by people that they go to for help. So we've heard about Catholic priests doing this, we've heard about therapists doing this, we've heard about people in prisons being sexually trafficked. In other words, the people in the organizations that are there to provide services can sometimes be the very same people that re-victimize individuals. And you know, people know that, and so they're kind of hesitant to reach out for help. And I wanted to say a little bit about trauma and memory. A lot of the professionals want to get the story, you know, like what actually happened. So you may in fact be a police interviewer, an investigator that wants to know the truth about what happened. And we all know that trauma makes memories difficult. It causes sequencing to get confused. The person's anxiety causes them to mentally block, and they can engage in behaviors that look contradictory to telling the truth. So one of the things that we've learned in terms of police interviews, because that's my area of research, is that people will remember a traumatic experience better when they're actually treated with trauma-informed care. So for example, asking a person if they're safe, helping them to feel safe in the room, helping them to feel safe in their environment, will help their memory actually get better. Telling them that they're brave for coming forward, that this is difficult, will increase their confidence and make them remember better. Asking the person what they wanted and what they felt in the situation will help them remember better. It'll bring them back there. And asking them about the 5 senses, what did you see, what did you hear, what did you smell, will kind of stimulate memories kind of organically, and they will come back. Last is giving the person control. Obviously, if you control someone who's already been tortured, raped, battered, you're actually re-victimizing that person. You're actually kind of treating that person in some ways in a parallel way to how they were treated by the abuser. So you want to make sure that you avoid any kind of actions you know, that might seem to replicate the very abuse that the person has suffered from. And again, in my police research, I've talked to people, survivors who've talked about having a gun at eye level when a police officer is towering over them in a room, blocking the door, and being asked exactly what happened during a rape, so that the person being interviewed feels like they're actually back there because of a lot of triggers in the room during the process of being interviewed. So we have to be careful about how we are in fact getting in the way sometimes of people being able to recall things, even though we may be asking them to recall those things. So spaces. So there are some people that just want to sit near the door because they want to be able to run out the door. So you may want to sit near the door when you're working with somebody so that you can feel safe. But in fact, the person who's sitting near the door is the one who's most likely to feel safe. So we have people that are not going to feel safe unless they can sit near the door. We have clients who want the door open so that they could run out of the room if they wanted to. And other clients that feel like it should be closed because they want that privacy. The way you dress, it could be something that you feel is your right. You could say, hey, it's my dress, it's my right to dress however I want to dress. So I'm going to wear my political buttons and I'm going to, you know, carry my gun, and I'm going to maybe dress a little bit provocatively because that's how I really express myself, and I have the right to express myself. So the issue with that is that some trauma survivors will read into those symbols and feel like they're being triggered again. This reminds them sometimes of their abuser. And when I think about waiting rooms, when I go into doctors' waiting rooms, often I feel that they make me uncomfortable. I might hear screaming. I might have to wait a long time. There may be disrespect, you know, about the way that different people are treated. We may be overcrowded, you know, and I understand that some of that's economic, but a lot of these everyday commonplace experiences of being in a waiting room can be highly triggering to people who've been tortured, imprisoned, and having a number of types of trauma. Okay, smells and things like that are also important. So let me see if I can share my PowerPoint screen.
And so if anybody is going to want to join the Q&A session right after, please start raising your hand or do the yes check mark for me or send me a chat. Thanks. Sorry.
Okay. All right. So here's some examples of situations where somebody might feel uncomfortable in a situation. Justin, 24, survivor of sexual abuse by his mother during bathing and showering, enters Miss Williams' office for the first time. He is greeted by a pair of beanbag chairs, one for her and one for himself. There is a mood lamp, but the room is otherwise dim. A fountain with pebbles adorns an end table. The sound of cascading water is heard. There is a smell of fresh lilacs in the air. So this is beautiful, right? Miss Williams is seated in the lotus position on the floor. She smiles and beckons for him to take a seat. He tells her he'd prefer to stand. So here's somebody, Miss Williams, and this is a real story. Somebody told me this story about his experience going for counseling. This is somebody who's taken great pains to try to create the most aesthetic, soothing, calming, trauma-informed environment she possibly could come up with, and he's being triggered by the sound of running water, the woman lying, you know, sitting on the floor in the lotus position, and the informality of it, the fact that there are no boundaries, there's no barriers in the room between them. And so he's being actively triggered. Here's a different example. Marshall, 17, is a survivor of emotional and physical abuse by his stepfather. Mr. Smith greets him at the door, gestures to a chair. Marshall sits. He notices that Mr. Smith's chair is elevated, whereas his own chair is low to the ground and faces an open window behind Mr. Smith. The sun streams into Marshall's face, forcing him to squint and look up at Mr. Smith, semi-blinded. Mr. Smith, seemingly annoyed, asks why Marshall is scowling. So here's the setup to a negative interaction between a professional and a client based on just the physical positioning of furniture in the room. And so it's kind of like an eye-opener about how important the physical environment can be, and about how, unless we take the position of the client, we really don't know what it's like for them to experience our services. Last, I want to talk about co-victims, which are other people who affect the survivor's chances of recovery. And these are the family members and friends who also have emotional reactions. And we don't really have time to get into that right now, but it's important for us to know that when we're working with a survivor, we also need to work with their family members, because often those people are instrumental in how well a person heals. And also they often don't get any help from service providers. But their reactions have a lot to do with whether a person develops PTSD. Because when you do research studies, one of the main factors in predicting PTSD is whether or not the significant others around a person are supportive. So I guess I've run out of time. Is that correct? Or do I have a little bit more time?
You've got 5 minutes. You're way under.
5 whole minutes. Hey, that's a luxury. So here's an example that I had put together. Very typical. Mike, 12, was molested by a janitor at his school. Jack, his father, is fearful that Mike may become gay as a result. Jack feels mortified that this got out, guilty that he didn't protect Mike, and angry that Mike did not fight back. Mike's been hiding in his room and refuses to discuss the incident, despite Jack's demands. And Mike's mother, Mary, had a similar event happen to her when she was a child, so she doesn't want to think about it. So this is a very typical situation where the co-victims are reacting in ways that only make it worse for the primary client. It's very important to meet alone with these people and ask them how they feel about this happening and kind of normalize their feelings. I'm trying to figure out whether something similar happened. We know this happened to Mary. Something similar happened to Mary. How did others treat her when she told them, if she ever did? So that helps somebody realize what it's like to be in that situation and what kind of reactions would help them feel better. And so what does it mean about you that your son might be gay? What does it mean that a janitor molested your son? Does it mean that you think you're a terrible father? Does it mean that you think you didn't teach your son how to defend himself? What are the issues for you? And how does this make you act towards your son? Once we have elaborated on this with the person and made them more conscious of what is playing into their reaction, we want to intervene and talk about trauma and healing and ways to respond to a survivor and how the individual can respond themselves when they feel triggered. How can you take care of yourself? What can you do so that you calm down to the point where you can be more helpful to the survivor? I think that's it. I think I
I think
spoke
you did
really
perfect.
That
You
was
did perfect at fitting everything in.